Good evening, Sweta.
गुड इवनिंग सर.
Good evening. Good evening.
अली सर, ये जो नीचे शेयर स्क्रीन है ना.
Good evening.
गुड इवनिंग सर.
Video पड़ेगा लाइव स्टार्ट माय वीडियो. Okay.
अली सर,
हाँ
ये जो शेयर स्क्रीन है ना, शेयर स्क्रीन,
हाँ हाँ.
हाँ, उससे आप जो प्रेजेंटेशन दिया है ना, वो आप शेयर कर सकते हैं.
Which presentation?
ओडी वाला एंड द C2C.
Sweta, can't you share from there only? Wala? Because I don't have that in the.
सर कर सकते हैं ना शेयर. आई विल शेयर इट.
हाँ, आप शेयर कर दो.
हाँ. चेतन, हेलो.
Yes, ma'am.
Chetan, I'll share you the presentation. Can you share it from your end?
Okay, ma'am.
हाँ, I'll send you that presentations. Okay.
Okay. Dr. SD Misra, can you hear me? Sir, you are on mute.
Yeah. All right.
Good evening,
Now
sir.
I'm audible.
Yeah, you are audible.
Okay, Mr. Ali.
Yeah. Good evening, sir. Dr. Surajit Sahu. Good evening.
Sir, please unmute yourself.
Okay, can you hear me?
Good evening, sir.
Yes, I'm here in the clinic. Yeah.
Yeah. Your voice is not audible, sir. Be loud.
Why? Is it
Yeah.
Why it's okay?
Yeah, it's okay.
Okay. Left. Two. Visor. Three. गरम सेक देना हॉट सोप बाहर भी गरम पानी रे कुली भी करी कर warm sir.
Good evening, Sujit sir.
Yes, good evening. ভালো
Sujit
আছো রে?
sir, good evening.
Hello.
Namaskar.
নমস্কার, ভালো আছো?
Again.
Okay, right. warm saline कर दो. नाक पर पानी पूरी और दियो.
YouTube guys.
Good evening, sir. Dr. Ashok Kumar Bera.
Am I audible?
Yeah, sir, you are audible. Yeah, good evening, sir. Good evening, sir.
Sir, namaskar.
नमस्कार नमस्कार
Namaskar.
अली साहब
Yeah, sir, good evening.
कैसे हैं?
बस बढ़िया सर.
तो कोविड फिर से बढ़ता रहा है.
कोविड तो इधर चारों तरफ बढ़ा हुआ है सर. इवन पटना, रांची, बंगाल.
ये हमसे वो इतना प्यार हो गया कोविड का, वो छोड़ के जाता नहीं है.
नमस्कार.
संदीप वेलकम. संदीप आउरी तमे माने लीन स्लिम एंड स्मार्ट है गलनी, पतला है गलनी पूरा. ये अशोक रेडी.
Sir, namaskar. Sir.
सुरजीत सर नमस्कार.
जादव नमस्कार.
नमस्कार सुरजीत सर, वेलकम.
Thank you.
Dr. Venkat Krishna will not be joining because he had some medical emergency, and there is only one medical emergency exists around, you know that. So first speaker is Dr. Sandeep Devashish, will be speaking about combinations. So
shall I start, sir?
No. Just in 1 minute we'll start. The second speaker is Dr. Ashok Behra, will be speaking about verified trial. And Sujit sir will speak about elderly patient. So we have 3 topics, isn't it? So the agenda is, first we'll have combinations, then trial, then elderly patients. And they'll be having a formal presentation and question, answer and discussion on the topic. And then we'll take the audience question. Fine. Ali sir, you can brief us regarding the agenda.
Agenda, sir, I will welcome you. Then followed by panel discussion. You will be the moderator in panel discussion between the 4 panelists. And finally, I will give the vote of thanks.
Fine.
So shall I start, sir, with your permission?
Now, what is the time for every speaker?
It is not, it's a panel discussion, sir. Entire agenda is of 1 hour, sir.
Okay. So
actually, there is no slides for presentation.
No presentation here, sir. Only the panel discussion among the 5 topics there.
Okay. So what time we must end the program?
Let us by 8.
By 8. So say.
Good, it is.
It's almost 7 o'clock. So in an hour's time, we should be able to finish up all 3 topics, because Dr. Vinil, Dr. Venkat is not here. We can also cover up the CKD and a little. So that's fine. Mr. Ali, you can go ahead to start.
Good evening, sir.
Yeah.
Am I audible?
Yeah, you are audible.
On behalf of Alkem Laboratories, India's 5th largest pharmaceutical company, I, Ahmed Ali, welcome our eminent doctors who have joined us for today's panel discussion titled Views on Vildagliptin. At Alkem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us navigate through the meetings, we have with us today as an eminent speaker, Dr. Jayant Kumar Panda, who will be our moderator for today's panel discussion. We take this opportunity to welcome moderator of the day, Dr. Jayant Kumar Panda. Let me have the opportunity to introduce Dr. Jayant Kumar Panda. Professor Dr. Jayant Kumar Panda, a well-known face in medical fraternity who is HOD of PG Department of SCB Medical College, Cuttack, and he has played a vital role in controlling COVID-19 last year and this year also. Let me introduce all galaxy of panelists also. The first panelist is Dr. Sandeep Devashish Mishra, consultant diabetologist and podiatrist. Second speak panelist is Dr. Ashok Pera, the consultant physician and diabetologist, SCB Medical College, Cuttack. Mr. Sujit Sahu, a senior physician, chairman of IMCA Indian Bhagatpur branch. Unfortunately, Dr. E.V. Krishna, consultant physician and diabetologist of Berhampur, who is due to a medical emergency, he is not joining today. We would like to invite Dr. Jayan Kumar Panda to set the contest and start the panel discussion. Over to Jayan Kumar Panda, sir.
Thank you, Mr. Ali, and thank you, the team all came for the nice CME on a very innovative molecule, the vildagliptin. We know that the gliptins, since they are launched, have shown us a different path in diabetes control, where not only we have a smooth A1C control, but beyond that, we don't have any side effects. The tolerance is maximum, and the patient has a affordable approach to this group of molecules. And Velda being one of the first drug to be launched. If you see the history of gliptins, after sitagliptin is the second gliptin to be launched, and the Velda, after it was launched, so many studies are conducted. It was the most one of the most studied gliptin in the world. And after it became off patent, it has become more affordable to the Indian patients. And when there is a competition between the all available gliptins, it has shown its efficacy, shown its safety very clearly with a very affordable price. And of late, the advantage has gone to the patients. Initially, what India had shed with the teneligliptin, now that's available with vildagliptin, and more people are able to afford this molecule, and this is going much accepted, not only amongst the poor to middle class patients, but also the physicians have taken up the molecule very well. The second thing I'll tell regarding the studies related to cardiovascular outcome trials, which is a must in present day era, and also regarding the renal safety, regarding the efficacy in terms of decreasing the A1C, and the safety in the elderly patients, and the combination, say with metformin, which is very common, or sulfonylurea, insulin, with SGLT2 inhibitors, with voglibose, alpha glucosidase inhibitors, and the host of molecules. So the combination therapy is very comfortably going with all available antidiabetic agents. And the patients, especially the CKD patients and the elderly patients, they tolerate the molecule very well. And few of the latest trials, like the verified trial, which has very clearly shown the efficacy and the safety of the combination of vildagliptin and the metformin. So we have a discussion today on the views on vildagliptin, and they're very important because it's one of the biggest weapon for controlling diabetes and achieving the end organ protection, as well as very comfortably controlling the problem with this molecule. And keeping that in view, we have this elite panel with us. We have Dr. Sandeep, who is working in the field for almost 3 decades, and being a physician diabetologist, is much experienced in controlling the patients. So, and then coming to Ashok, is a promising faculty in Department of Medicine at SCB Medical College, and much into helping people in the blood glucose control. And Dr. Shurjit Sahu is known to all of you. It's a committed metabolic physician who has been working in this field for long. So without much delay, I request Dr. Shandip Devasis will be speaking regarding the vildagliptin and combination. We have not taken any didactic presentation or slides, but we'll take the opinion of the experts and we'll also take the opinion of the house, the speakers who will like to put their opinion, and we'll take the cross opinion of the panelists and then conclude finally. So Dr. Shandip Devashish Mishra will be taking up the very burning issue of vildagliptin and combination, because so many drugs are there. And when we are using a molecule, it should go well, not only with insulin and metformin, but also with other drugs like sulfonylurea, like alpha glucosidase inhibitor, like say SGLT2 inhibitor, let's say glitazones, and we should be able to make a cocktail of the drugs for the better control of the diabetes and better safety of our patients. So to start with, I request Dr. Shandip to roll the ball, starting the discussion on the vildagliptin and combinations. Dr. Shandip Devashish Mishra.
Thank you, Professor Dr. Panda, for introducing me to the audience, and a Corona Namaste to all the audience and presenters. Let me start with sharing this slide. Just a minute. Now the slide is visible.
Yeah.
Yes, Shandip.
Now the slide is visible.
Yeah. Yes, Shandip. It's visible.
So
please go ahead.
We'll be discussing on the oldest gliptin or DPP4 inhibitor. Why I'm saying it as the oldest? Because being a DPP4 inhibitor, it was first invented. It was invented in the year 1998, May 1998, and the inventor was Dr. Edwin V. Wheeler. So accordingly, to keep his name and for his novel invention, so he coined his name Wheeler, and DA for diabetes, GL for glucose, and IFT for dipeptidyl, and IN for inhibitor. So this vildagliptin name was coined by Dr. Edwin V. Wheeler according to his name, and so that the entire world will remember his name. Next, coming to this slide, the IDF Diabetes Atlas. So it is an older one in 2019. So it is known to almost all present here. So I'll not waste any more on discussing this. It has been discussed near about not less than 100 times and seen 100 times each and every participant over here. So what are gliptins? We know. So before starting discussion, let us start diagnosed type of a new type without complication. The duty of the team is to persons with diabetes that is disorder, which will worsen day to day with advancement of age and duration of time spent in the uncontrolled state. Counseling of family members to tackle with the persons with diabetes, investigate thoroughly about any coexisting comorbid conditions like hypertension, CAE, disorders, nephropathy, retinopathy, neuropathy, and find out such an agent or in combination with other agents which will slow down the progression of diabetes mellitus without adverse effects in a pocket-friendly price. When we discuss about the person,
Dr. Shandip, you are disconnected. I think by the time Dr. Sandeep is connected,
Sir,
we
connected
can-
now, sir.
connected.
Sir,
I'm not audible.
Sandeep, yeah. Dr. Sandeep, your connectivity is poor.
Yeah.
So and your
Oh.
voice is also breaking and you're disconnected at times. So please
So
say,
I'll do one thing. I'll switch off the video.
yeah, switch off the video
I'll
and
switch off my
share
video
your slides.
and the slides will be displayed.
Yeah.
Yeah. So I'm stopping the video. Okay. So now I'm audible.
You share your slides.
Yes, slide is there.
My slide is not there.
not there, sir.
Oh, not done. Okay.
Sir, in bottom there is a share screen option. First click on that and choose your slide and click on share option.
So it was unshared. Okay. Just a minute. Yeah. Now it's visible.
Yes.
Yes, it has come.
Okay. So the available treatment options will be according to the conditions of persons with diabetes. Like first line, usually we advise to prescribe biguanides, and now the only available biguanide in the market is the metformin, age-old brand. So many positive findings with metformin that it is the best drug. It should be started early, and it addresses the insulin resistance. And then comes the thiazolidine, or we could say the glitazone. And the available glitazone in the market is now pioglitazone. Then DPP-4 inhibitors, or what we popularly known as gliptins, and the cheaper ones are teneligliptin, alogliptin, and now after post-patent, vildagliptin is also cheap, and other gliptins are sita and linagliptin. Then SGLT2 inhibitors are what we popularly know as gliflozins, and the cheap ones are and after post-patent now dapagliflozin is also cheap. Other gliflozins are empagliflozin and canagliflozin, and sulfonylureas like glibenclamide, glimepiride, glyclazide, glipizide, and non-secretagogue non-sulfonyl secretagogues like glinides or ripaglinide, nactiglinide, alpha-glucosidase inhibitors like acarbose, voglibose, miglitol, and insulins, two different types broadly, conventional and analogs. Conventional, what we say as human insulins, and analogs as the newer insulins. All these treatment options are available for our persons with diabetes. And so far as we know,
Sandeep, you can stop the video because the connectivity is poor.
Okay.
The details of the slide are also not downloaded. Or connectivity.
No, it's that downloaded. Yeah.
So what gliptins that we already know are, it is the efficacy is similar to other oral antidiabetics, and the efficacy in real life and in Indian patients is even better. And the baseline dependent HbA1c reduction is good as per the data available, the durability data. And it works in all stages of diabetes, early, late, with all drugs and with insulin also. So it has a placebo-like safety profile, like less hypoglycemia and less chances of weight gain, or say weight neutral. And the promise of beta cell regeneration is also there with gliptins. So some facts about vildagliptin, that it got its first approval in March 2007 in Europe, and in January 2008 it got the approval for being marketed in India, and it is now available more than 100 countries. The approval has been received, and it has more than 10 years of clinical usage data. So what are the what is the pharmacokinetics? It is 85% orally bioavailable, and nearly 9% low plasma protein binding capacity. And the most important is it is not metabolized and does not inhibit or induce the cytochrome P450 enzymes. So there are, due to these two things, there is a low risk of drug interactions, and the 85% of vildagliptin is eliminated mainly by the urine or renal excretion. and 2 to 3 hours of elimination half-life is there. So the profile of vildagliptin is like this. Indication is as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes mellitus. And the dosage is 50 milligram BID orally with or without food. And in hepatic impairment cases, it is not recommended in patients with a pre-treatment SGOT or SGPT, which is 2.5 times the upper limit of the normal level. And in renal impairment cases, there is no adjustment in mild cases. And in patients with moderate or severe renal impairment or in end-stage renal diseases, on hemodialysis cases, the recommended dose is 50 milligram once daily. And in elderly cases, there is no requirement of adjusting the dose. Pediatrics, it is not recommended in persons with diabetes less than 18 years of age. In pregnancy, not to be used during pregnancy, and during lactation also not recommended for use. And the VERIFY trial, it is to be addressed by Dr. Ashok Behera. So I'll wind up here, and we'll have a discussion after the entire session is over by the presenters, and we'll have discussions on that. So thank you, and over to you, Professor Panda sir.
Thank you, Shandip, for that brief and very clear presentation. Always diabetes has been a progressive disease, and the beta cell atrophy or apoptosis is a continuous phenomena, and we have a decline in the beta cell population, leading to more and more requirement of the drugs followed by insulin. That's the natural history of diabetes. And if we'll see, when it's a beginning with one drug, we go for the second drug, third drug, even fourth drug and fifth drug in India, and then finally we plan the insulin. And again, with insulin, we go on adding oral drops with the hope that the A1C will come down and control will be smoother without much higher dose of insulin. Keeping in view, Dr. Mishra has shown you how safe are the combination, especially with metformin, which is a very common combination to start with, because with a A1C of 8.5 or 9 or even 8, we are comfortable to start only metformin or only one drug. It's a combined approach that we start with multiple drugs and get a good control and maintain the A1C which is achieved after that. So keeping in view of that approach with multiple drugs and gradual deterioration of the beta cell function and the ability of vildagliptin to go well with all the molecules, especially metformin, sulfonylurea and metformin combination, and SGLT2 inhibitors, besides the drugs like glitazones and alpha glucosidase inhibitor. The vildagliptin is a very common add-on, and if we are giving vildagliptin, we can expand the regimen with other drugs. So thank you, Dr. Mishra, for that. We'll take up the questions at the end. With this, we'll move on to Dr. Ashok, who will be speaking to you about a very latest trial on a combination therapy of vildagliptin and metformin. That's the VERIFY trial about vildagliptin. Dr. Ashok, as I have told, is a senior faculty in Department of Medicine at SCB, and we present you Dr. Ashok Behera. Dr. Ashok, please go ahead.
Thank you, sir, for your kind words. Sir, am I audible, sir?
Yes, you are audible.
Yes, sir. Thank you, sir, for your kind words. And good evening to all. I will tell about the VERIFY trial, which is one of the latest trial about the DP4 inhibitors, that is on vildagliptin. So, sir had already told about the gliptins and the emergence of gliptins and comparison of different gliptins starting from the success, sitagliptin, lina, and vilda. So, we will discuss today about the vildagliptin. Vildagliptin, one of the trial. VERIFY trial means vildagliptin efficacy with vildagliptin efficacy in combination with metformin for early treatment of type 2 diabetes mellitus. This is one of the VERIFY trial. This VERIFY trial was started registration in 2012, March 30. and registration ended at April 10, 2014. They had taken 2,100 patients and they had divided into two groups. In one group, they given the only metformin, and other group they have given metformin along with vildagliptin. Vildagliptin 50 milligram twice daily, and metformin they increased from 1,000 milligram to 1,500 and 2,000. And other group only metformin, they start 1,000, 1,500 and 2,000 milligram. But they observed in the combination group, that is vildagliptin and metformin, they have selected 998 patients and only metformin 1,003 patients. They had taken, the study was conducted in 2,054 centers in 34 countries. Initially, they had taken the patients whose HbA1c level was in between 6.5 to 7.5, and the BMI was 22, in between 20 to 40, and the age was 18 to 17 years. But they found the metformin, the patients who had received only metformin, they had shown also the decrease in HbA1c level, but the level of decrease is less as compared with the metformin and the vildagliptin. And what the found the failure patients, those patients who had received either combination of vildagliptin or metformin and or only metformin, if the HbA1c level is not decreased below 7, they had taken consider, or they have taken those patients as failure patients. So the patients who have received both vildagliptin and metformin, they have shown very good reduction in HbA1c level. Just like the other, why vildagliptin is very important. Vildagliptin, if we compare gliptins, vildagliptin has very good efficacy, and just like other gliptins, it has also separate mechanism of action, and it also helps decrease insulin, increasing the insulin sensitization, just like metformin. So when the metformin and vildagliptin combination were given, the patients have better reduction in HbA1c level and the blood sugar level control. So longer duration of glycemic control is achieved in combination with metformin and vildagliptin. But what are the disadvantage? This group was not powered to verify the cardiovascular outcome. What is the greatest advantage of this trial? The greatest, one of the greatest advantages, this is multi-centric trial, and it is geographically distributed, and it is a multi-centric population trial. So in all areas we could estimate the combination therapy is better. So what they conclude, their aim was to initially treatment as early as we start the combination therapy, the outcome is better. The patients who had started with only metformin, they showed less results in comparison with the patients who were started vildagliptin plus metformin as early as possible. So their conclusion is that treatment approach with vildagliptin plus metformin in patients with newly diagnosed type 2 diabetes significantly and consistently improves long-term glycemic durability as compared with metformin monotherapy. So our results indicate that long-term clinical benefits can be achieved more frequently and without tolerability issues with the early combination treatment compared with the standard of care medication metformin. Thank you, sir.
Thank you, Dr. Ashok. Very nicely, he has told about the verified trial, that instead of starting only with metformin, if we combine vildagliptin and metformin, there are multiple benefits. The first one, we prevent the treatment failure. If you start with a single drug, there are chances of treatment failure. I was already telling you that if A1C is 8 or 8.5, instead of one drug, we have to go with a combination, which works better. So there are less chance that you start with metformin, after 3 months you see a higher A1C and you go for addition. So you start with both the drugs, vildagliptin and metformin. And second, after the early initiation, the primary treatment failure is prevented, and the secondary treatment failure is also prevented, and the time to addition of the drugs is reduced. So it was concluded that instead of going one after another additions, starting a combination of vildagliptin metformin early in the course of disease in a poorly controlled diabetic can be productive, can be useful, decreasing the incidence of primary, secondary failure, and also achieving early A1C control. And so there is a clear message of advantage of this combination, which Dr. Ashok has clearly mentioned before you. With this, we'll move on to Dr. Shurjit Sahu, our senior most physician present today, who will be speaking to you on a very important topic of vildagliptin in the elderly patient. You know, when we are dealing with elderly patient, always we want that there should not be any side effect. The renal and the hepatic parameters should go very well. Patient should not have hypoglycemia, which is very detrimental at the elderly age. There occurs cognitive dysfunction. And besides this, the safety and efficacy part has to be monitored very stringently in this group of patients. So keeping this in mind, how we should proceed with the elderly population mass, and what is the role of a very old and innovative gliptin like vildagliptin in planning the antidiabetic therapy in this group of elderly patient will be covered by Dr. Shurjit Sahu. So we present you Dr. Shurjit Sahu for the topic vildagliptin in the elderly patient. Dr. Sahu.
Thank you. Thank you, Dr. Pata. Am I audible?
Yes, you are audible, sir.
Am I audible?
Yes, sir. You are audible.
Okay, thank you. Thank you so much. Thank you, Dr. Jayant Panda, for giving me an elderly doctor with 48 years of experience to talk on the subject of the management of diabetes for the elderly people. And what I would like to share here is some of the social issues and also some of the socio-economical issues which are involved in treating with the diabetes and treating with the diabetes patients with elderly population. As we know that the prevalence of type 2 diabetes increases with age, and older patients have an increased load of developing type 2 diabetes, and related to that is the comorbidities and also mortalities also increase. So we have certain challenges in managing type 2 diabetes in elderly people with the increased prevalence and the incidence of the cardiovascular risk factors. Now let me share with you some of the problems of the elderly. Now the elderly people, when we consider them, that age, demographic age is one of the points which we have to consider. It is not only the demographic age of a person, but also the diabetic age of the people those who are suffering from diabetes mellitus. And then this is since long time, they are suffering with the diabetes, and prolonged longevity due to the modern medical advancement and the research in the medical field has kept our longevity to a very elderly persons. So what we see now is a lot of elderly people. And the other challenges which has come up is the lots of research. Am I audible?
Yes, sir.
Am I audible?
Yes,
Yes,
sir, you
sir.
are audible.
Yes, you are audible.
Yes, sir.
Very well
Audible,
audible.
sir. Audible.
Actually, a lot of research has been done on the younger or the other citizens, but hardly any research is being done specifically only for the elderly people group. Therefore, we have got plenty of research which has been done. All the trials that has been done is for the common people of the diabetes, but specifically for elderly people, hardly, not a lot of research has been done in the elderly group of people. Now, when we consider about the elderly people group, I would say people group, there are full of comorbidities with polypharmacies. This is the problem that elderly people, they usually face, because they suffer from not only from diabetes, they suffer from hypertension, dyslipidemia, and other comorbidities of different other causes, with senile changes in the brain, causing a lot of loss of damage, and then the dosage drop down, or maybe double dosage, because they forget to take the medicines. Therefore, sometimes they lose the dosage, or they might have taken one dose and then they forget about that. And then they say that, yes, I have not taken that medicine. Therefore, they take the second dose also. So this is what the senile changes that occur with the brain, and then the loss of vision and the sight. With elderly people, there's a cataract development, diabetic retinopathy, and other development is there, where the vision, the sight becomes a problem, and therefore to pick up certain drugs, it becomes difficult. Therefore, some assistance has to be given to these people, that that they need to be helped for this group of people. And it's not only that, but it is again a social issue, that negligence on the part of the family members and the children and the grandchildren, it becomes a problem again for the elderly people group to be treated with for the diabetes. Now, with this present situation, the care of the elderly people is been hampered, because from the joint family system, we are moving out to the single unit family system, and therefore the elderly people are neglected to a lot of extent. This is only few social issues and the social economic issues, in a sense that, so supposing a person is becoming about 70 or 80 or 90 years of age, the people or the family members, they think that, okay, what is the use of treating these elderly people? So there's a neglect also on the part of that. Not only that, in religious rituals causing hamper to the treatment. What are the rituals that we have? Yes, supposing now we are in a season of Ramadan. Now we are in a season of Ramadan, where the fasting starts from the sunrise to the sunset. And when we have this problem, then elderly people, usually they are afraid of taking the fast and also taking the treatment. So by that time, they have mentally depressed, and also that they cannot maintain the fast. And sometimes these are social and socio-economic issues also comes out. So in those cases, what I usually do is that, well, we have to, when the Ramadan starts, now supposing yesterday it has started, and they'll be fasting for about 1 month, we have to reschedule the treatment pattern, reschedule the timing of the taking the medicines, and reschedule the medication also, so that this becomes not a problem for the elderly people, especially for the Muslim community. And also sometimes what happens in the elderly people, the social issues also comes out, that yes, the audacity of the elderly people for restriction of diet. You know, all these years they were enjoying their food, and then once you state that, okay, these are the restricted food habit, restricted lifestyle, restricted, and then more of exercise and other things, starting of the exercise and other things, this becomes a problem to be accepted by the society, especially by the elderly group of people. See, these are a few factors which are important, the challenges that we have. But in this juncture, we are so glad that we have our two panelists. They have already discussed that the vildagliptin is one of the very safe medicines. And what they have, the comorbidities, along with the comorbidities, the elderly people group, they have with the comorbidities of hypertension, CVD, and then CNS problems. And not only that, sometimes they go into hypoglycemia if they are taking some of the medicines. But thanks to the invention of the gliptins, the DPP4 inhibitors, thanks to the development of these products, which are also helping the people to allay over the hypoglycemia problem, and then they can be treated well to prevent certain of the comorbidities. Not only that, but also they can have these problems can be overruled. But what I would say is that in elderly people, when we are dealing with them, we have to depute the family members. Because the family members have got the responsibility to take care of the elderly group of people, their parents, their grandparents. Therefore, one family member has to be taken, given a deputation to take care of their family and take care of the elderly people, and then see that they are taking their medicines all right. So these are the few of the challenges, problems of the elderly people. But thanks to the modern medicine, this vildagliptin, what I would like to say is that vildagliptin, as it has already been discussed, the vildagliptin is quite safe in the treatment of elderly people, and there's a less chance of hypoglycemia, even though there are plenty. And then nowadays that vildagliptin twice a day dose was there, but now that the sustained release tablets of vildagliptin 100 milligram is again helping hand to the elderly people so that they can have only one tablet and forgetting about the twice a day dose. So these are the few things, social issues and socio-economic issues, and also the challenges, how we can overcome that. And therefore, I'm glad I could get some time to share about this problem of the elderly people. And then I think they'll get a benefit out of this. And what I would say, even request that if, especially for elderly people, some research is to be done, I think these vildagliptin people can also do some of the research work only for the elderly people group as to what are the sequence that they have. And also the once a day dose that is sustained release of vildagliptin 100 milligram also can be taken as a challenge to them. Thank you so much for this August gathering.
Thank you, Dr. Shao. Very clearly, sir has told that this is not only safe in elderly, but it is efficacious. The incidence of hypoglycemia is very low, and you can give to the patient, even the patient has moderate renal impairment with the dose reduction. And he has also expressed his interest in further studies in the elderly, and because he's a senior citizen and also deals with so many patients who are elderly, it's a very expert expression, and also very welcome suggestion from Dr. Shao. So thank you, Dr. Shao. Thank you all the panelists, Dr. Mishra, Dr. Behra, Dr. Shao. And to just summarize very lucidly, all the speakers have told the different aspects. Dr. Mishra about the combinations, different drops, how its efficacy is increased, and Dr. Behra has how combining early with drugs like metformin, how we save our patient from primary and secondary failure. And Dr. Shao has told in the elderly. Dr. Venkat has not been able to join, so I'm just touching upon these two aspects which was there in the today's agenda. One was CKD, vildagliptin in CKD, and one was vildagliptin in post-patent era. Before we take up the questions, we know that the gliptins are completely safe. Few gliptins, they don't require dose modification, like linagliptin and teneligliptin. Few gliptins, they require dose modification, like sitagliptin, the vildagliptin, and other gliptins. If we tell vildagliptin, it's completely safe till we have estimated GFR up to 30. And below that, we need to reduce the dose. So instead of 100, we can give 50. Instead of 50, we can give 25. So the amount of dose is half when the GFR comes below 30 or comes below stage 3. So there we can use up to a patient who is till the end stage renal disease, and it is safe in them, and also controls the A1C very well. So in CKD patients also, you can consider the gliptins like vilda without much concern, and with the appropriate dose reduction in the appropriate phase. So say it be with combination, say it be in elderly, should be in CKD with hepatopathy. This is a safe drug, and we can give the patient to an affordable cost in this post-patent era. You know, previously per day cost was around 45 to 50 rupees and amounting to around 16,000 rupees a year. But post-patent era, this is almost 1/4. So we have a cost of around 10 to 12 rupees per day, depending on the brand. And the cost has come around 4,000 rupees in a year. So in such a situation, giving the advantage of vildagliptin, which is a trusted, well-studied gliptin to our patients with an affordable cost, is an opportunity. So what I'll tell you that when vildagliptin has come with a much affordable price, especially for Indian patients who spend from the pocket and don't have an insurance support for the molecule, they are very comfortable in spending this much for their good control with quality drugs which don't have a side effect, don't have a much unwanted effect on the patient, with a very smooth control of A1C, and especially speaking, without any incidence of hypoglycemia in patients of CKD, in elderly patient, and a good CVOT, good hepatic outcome in patients with hepatopathy, and with a good control of A1C. And if you are giving this, there is hardly any chance of any untoward, any unpleasant side effect. So with this, we'll take the opinion that it's not only it was a very efficacious and safe molecule for our patients, but in a patient who has renal impairment, hepatic impairment, elderly, special category patients, also this is safe, and this has the promise of a good A1C control all the time. With this conclusion, I thank all the panelists, and now I will be happy to take up questions, if any, from the panelists to the other panelists, or from the audience to the chat box, if any, to be managed by Mr. Ali and Shweta. Mr. Ali, we have any questions for us? Chetan? Shweta?
No, sir, we don't have any question from the audience at present. No.
Yeah. From the chat box or the question answer box, we don't have any questions. So if there are no questions, I request the speakers to give their concluding remark before we close the session with a vote of thanks. So to start with, Dr. S.D. Mishra, your final opinion after the discussion.
So, sir, when we discuss about the post-patent era and discussing about the combination therapy along with vildagliptin, so my take is that this is the ideal gliptin to be given, as because among the cheap gliptins which are available in the market, it has having the highest number of data favoring administration of this agent in different types of diabetics. So we can safely administer alone or as a combination therapy in different categories of patients.
Fine. Very well spoken. Dr. Behra?
Sir, my final opinion is regarding there are so many DPP-4 inhibitors, but here I can stress that no weight gain unlike on conventional therapy. And another is negligible drug-to-drug interaction, and this also improves the beta cell functions. And another thing is that the long-term and sustained reduction in HbA1c level. So if you treat vildagliptin along with the combination of metformin, we can see or delay the organ involvement in long-term use. And this is very safe in elderly patients. This much I can add. Thank you, sir.
Yeah. Very well spoken. So started early in combination, both vildagliptin and metformin, we can have less incidence of primary or secondary failure, and there can be good glycemic control resulting in good metabolic memory and good long-term outcome in the patient without complications. Dr. Shahu, your final opinion regarding vildagliptin?
Thank you. Thank you, Dr. Panda. My final opinion and then request to all the panelists, and also not only the panelists, but also the doctors, those who are online, is that the elderly people should be taken care of. The social issues, the socio-economic issues, I would request all the doctors to discuss the social issues with the patients and elderly patients, and also with their family members. When they deal with some of these elderly people, I think one family member has to be there, accompanied with him, and so that they can be shared about that, and their problems can be sorted out. And I would say that, yes, this is one of the best gliptins that we have, vildagliptin, which is quite safe, and also it can prevent a lot of complications like hypoglycemic status, or any of these complications can be prevented. So the social issues and the social economic issues also, I would like to request all the doctors to consider and discuss with the people. Thank you very much.
Thank you, sir. Very well taken. And rightly you have told that we have to discuss about the treatment, side effects, complications, especially with the caregivers. When problems like hypoglycemia occur, that should be detected in time and corrected, because that's an important issue in preventing the comorbidity, and the patient has a smooth sailing with treatment if that doesn't happen. And if a patient doesn't take well and we go on treating, that's very difficult. And especially the drugs like sulfonylurea, long-acting, which are the second generation or the third generation sulfonylureas, it can be very fatal at times, causing hypoglycemia, and we have seen people dying out of it. So we must talk to the attendants regarding complications like hypoglycemia, complications like taking food in time, and when selecting drugs, we must select drugs which doesn't have such potential to decrease the blood glucose and cause the harm. Thank you, Dr. Shahu. We have a couple of questions in the chat box.
Yes, sir.
Yeah, forwarded by Chetan. I request Mr. Ali to take up the questions so that our panel can...
there is one question from Dr. Arpati. Dr. Arpati, how can we differentiate between Sita and Vilda while treating DM patient, diabetic mellitus patients? Asked by Dr. Arpati.
Yeah. So both are gliptins, Sita and Vilda, both are gliptins, and you know, both are not very long-acting gliptins, and we prefer to give it even multiple times. Though sitagliptin is mostly preferred for once daily, at times the dose is increased for the good glycemic control, and sitagliptin is the first gliptin to be launched, followed by the vildagliptin, and telling the overall side effects in the patients with carcinoma pancreas or the pancreatitis, patients of pancreatitis, we try to avoid this group of drugs because they're incretin therapies and they don't go very well with pancreatic diseases. Or else, if we'll see the CVOTs, the outcome trials and different trials of the gliptins, if you say one of the most accepted evidence-based and safe and efficacious gliptin is Vilda. If you ask me personally, the vildagliptin scores over sitagliptin in treatment because of the A1C controlling ability, safety profile, as well as the affordability at present. Now, you won't get sitagliptin at the cost where the vildagliptin is affordable to our patients. So that's why if we have patients who are on Vilda, they are very happy, you'll see a smile in their face, and that's how you differentiate between patients on Sita and Vilda. Sita will be a little groomed because he'll be spending more from the pocket. Any of the panelists, anything if you want to comment?
Thank you very much, Dr. Panda. There is one question from Dr. Govind Agarwal.
Yeah.
Because Alkem has recently launched Gluvilda 100 milligram once daily. So the question is how vildagliptin 100 milligram can be given as OD dosage, whereas the recommended dose is BID. This is asked by Dr. Govind Agarwal.
Yeah. Actually, in pharmacokinetics, we prepare molecules which work for longer, and for the patient convenience, the twice daily doses or the 12-hour half-life is extended to 24 hours. So this 100 milligram vildagliptin OD preparation is such a preparation which has been modified with a half-life of almost a day, and you need not just give it more frequently. Those who forget to take in time, those who don't take regularly, those who travel more and forget taking the drug, and chances of missed dose is there. And in them, either in the morning or in the night, if you want to give once, you have to take drugs which are once daily. And this once daily vildagliptin has a sustained release over 24 hours, and it has a smooth control of blood glucose and A1C, what has been verified with continuous glucose monitoring. So that's that message I want to give you, Dr. Govind. And we have to utilize this technology for the convenience of the patient. And we know there are many other molecules, including metformin. Metformin is given 8 hourly, but we have once daily preparation. And many twice a daily preparations like glyclazide, it has once daily preparations. So in diabetes management, because patient takes a lot of pill, we have many preparations which can comfortably be given once daily with a modified pharmacokinetics and very well accepted for the patient, and the compliance is improved.
That means that this is mostly done for the compliance of the patients, and the patient should not miss one dose. And for the convenience of the patient can take at any time at once daily.
Yeah. That's what is the message.
Told, sir.
Yes, that's what the message. So any faculty wants to put any comment, or we'll wind up. We have 2 minutes more. Mr. Ali, we have finished in time.
Yeah, sir.
You must send us chocolates by courier or by Zomato, so that in the pandemic, I'm happy.
Thank you all the team of Alkem for a nice discussion, and thank you Panda sir. So we am very happy that you have moderated very so nicely. Thank you, sir.
Thank you, Ashok. So finally, Mr. Ali, to conclude, and we'll close the session.
Thank you very much, sir. We take this opportunity to thank Dr. Professor Joyan Panda for moderating the panel discussion, and all the panelists for sharing their views on vildagliptin in the clinic practice. We'd also thank all the doctors who have joined us for the panel discussion, and I'm sure you will appreciate the views on vildagliptin present today. We at Alkem Laboratories will continue to serve doctor and patient by making our products available, especially our chronic brands like Gluvilda M, Jupiros and Alkem. Thank you, sir. And we have recently launched Gluvilda OD preparation, sir. Just 5 days back, we have launched this product. So it is available. Thank you very much, sir. Thanks.
Thank you. Thank you, everyone. Thank you, everyone. With these words, we'll wind up and expecting more academics during this COVID time, so that we can keep ourselves engaged and the virus will not divert our mind for unwanted regions. Thank you. Sir. Thank you, Alkem. Thank you, panelists. Thank you, viewers. Thank you, listeners. And hopefully, you'll utilize the benefit of this affordable vildagliptin for the glycemic control and safety of all your patients. Thank you.
Thank you.
Thank you very much
for your encouraging words.
Thank you. Thank you, Ashok.
Thanks, sir. Thank all panelists. Thank you and good night.